study, which is I'm part of my team. The title of the study is Structures Deep Breathing Exercises Education in Patient with Coronary Artery Bypass Graft. And my name is Suryanto, and I'm coming from School of Nursing, Faculty of Medicine, Universitas Brawijaya in Indonesia. And in here, I have the member of the team, which is Ms. Nurhaini Hashim, Ms. Nurhaini Majid, and also Ms. Norizan Mazri, coming from Center for Nursing Studies, Faculty of Health Sciences, Universiti Teknologi MARA in Malaysia. So during this event, I will present, which is the outline is like this. All right, good. So this is the outline of my presentation today, which is introduction, methodology, findings, discussion, conclusion, and also recommendation. Start with introduction. So as we can already know that the normal breathing pattern gets affected in several ways, including surgery such as CABG procedure or coronary artery bypass graft procedure. And based on my team experience and also the data that the number of patients getting CABG is increasing year by year. So it's quite interesting to study about these cases. Yeah. And instead of the preoperative evaluation and preparation of the patient for cardiac surgery affect postoperative outcomes and progress, including with this patient. As the nurse's attitude affects the amount of information given to the patient, we should have a standardized preoperative education, which may ensure the adequate and correct information is provided to the patient. So by providing well-organized education prior the procedure, prior the operating theater procedure, it will have influence in how the outcome of the patient, especially in patient coronary artery bypass graft procedure. And there are limited, however, there are limited studies on the effectiveness of structured deep breathing exercise on oxygenation in post-CABG surgery patients. And therefore, we are investigating this study, yeah. And the aim of study is the investigating the changes in the oxygenation measurement level and development of pneumonia pre and postoperative after a structured education program is given. And in terms of methodology, the research was conducted in one of the cardiothoracic unit in the tertiary hospital situated in Selangor, Malaysia. So as part of the team, I did not involve within the data collection, but I was involved in the data analysis and also the establishment of the manuscript of the paper. And the study was quasi-experiment design, and this was a non-equivalent control group before and after design. We have two groups, which is the control group receive routine deep breathing exercise by physiotherapy, which is the number of participants was 50. And also we had intervention group, which who receive a regular deep breathing exercise plus a package of breathing exercise a day before the operation with the number of participants 51. And the structured preoperative education was delivered one day before the surgery by the researcher supported by the pamphlet. The pamphlet contains contents included the aim of the deep breathing exercise, the active cycle of breathing, part of active cycle of breathing exercise, and the illustration of deep breathing exercise. There was an instructor's manual with the detailed information of the deep breathing exercise. And after the routine pre-operative teaching, because despite of providing the the deep breathing exercise, we also have the regular education as just regular activities, the regular procedure before the patient getting the procedure of the operation. After the routine pre-authorization, we have both group. We measure the SpO2, were monitored by pulse oximeter at chest and finger, and then measure ABG a day before operation. And then we also measure ABG 2 times, which is a day 1 after the operation and day 2 after the operation. We call POD1 and POD2. And what about actually deep breathing exercise? The exercise was started approximately 1 hour after extubation, and the participant had been encouraged to perform 30 deep breaths once per hour when awake in the daytime for the first 2 post-operative days. The exercises included 3 sets of 10 deep breaths over 15 minutes with a 30 to 60 seconds pause between each set. The participants were performed 3 to 5 deep breaths interspersed with periods of quiet breathing, followed by 2 or 3 cough and huff with one support by pillow or hands. It really depends on the situation. And if they did, the participants were asked to cough during the pause to mobilize the secretions. And this is the findings of the study. Start with the socio-demographic characteristics, including gender, age, and ethnic group. We can see here the table that there is no differences between gender, age, and ethnic group within the participants. And but we can see in here that the control group, the majority are a male, including the intervention group also male participants. And based on the age, we can see here that the majority was the more than 60 years old, and the majority of the people were coming from the ethnic Malay. What about the education level? The education level, there was also no difference between among the participants. Working status, prior hospitalization, and prior to surgery, there is no significant difference among the participants. And this is the one we are interesting, which is the findings coming from the pre-intervention, pre-operative, post-intervention, pre-operative, post-operative day 1, and post-operative day 2, or POD1 and POD2. In here we can see, which is the ones we are with the circles, that we had a significant difference between control and intervention groups of the post-intervention, the pre-operative, and also the day 1 and day 2 of the post-operative between the control and also intervention groups, which is the p-value is 0.041 for the post-intervention pre-operative, and also the 0.27 and also 0.023. And this is the PL2 scores. We can see here that there's a difference between the post-operative control intervention, which is 0.008, and the other is not really different. And what about the discussion? In the study, there is also no significant difference on pre-interventions and post-intervention. However, after education of deep breathing exercises, the PaO2 score will increase in the intervention group, which is the p-value 0.008. And the alternative hypothesis was accepted with significant differences between patients who received the routine pre-operative education plus a structured pre-operative education intervention on SpO2 level during post-operative day 1 or POD1. Thus, the respiratory physiotherapy on patients undergoing cardiac surgery may reduce post-operative pulmonary complications and hospital length of stay. The content of pre-operative education package should be simple and informative to ensure the effectiveness of the pre-operative education among post-coronary artery bypass grafts (ABG) surgery patients. And to conclude, that the researchers strongly recommended the implementation of a structured pre-operative education. A similar approach in this pre-operative education could be adopted for the development of other education of other surgery or procedure. A more comprehensive delivery of pre-operative education intervention setting up by a multidisciplinary pre-operative team is suggested. And that's it, my presentation. On behalf of my team, we would like to thank our colleagues from the Universiti Teknologi MARA who provided insight and expertise that really assisted the research. And also we thank to all the participants, nurses, physiotherapists, dietitian, and medical attendant in cardiothoracic unit for the support and collaboration during data collections. And that's it. Thank you very much. And back to Prof. Ranjith.
Thank you very much, Dr. Suryanto, for that very interesting presentation about the education of deep breathing exercises after this post-coronary bypass surgery. And the idea of respiratory physiotherapy seems to be an interesting one. I have a question. It seems like such a practice doesn't exist at the moment, and this particular practice is likely to help the patient tremendously. Is that right, as you are trying to conclude?
Yes, so currently we only provide like a regular, education for the patient undergoing the operation, but for the structured deep breathing, it's not regular. Will be provided to the patients, and we are suggested that because of the study, we are suggested that it must be part of the compulsory, not compulsory, like, regular education prior to the procedure of the operating surgery.
And in your recommendations, how long do you think that the breathing exercises should continue post-surgery?
Well, the study is providing the education before the surgery, but then the practice of the deep breathing, we are undertaking the implementation of the deep breathing surgery after 2 days after the surgery.
And for how long?
For 2 days, yeah. Or each day? Do you mean each day?
Mm-hmm.
Yeah, for each day, it is recommended that the patient can have the deep breathing at least once per hour. Yeah, so it can be up to 30 deep breath once per hour, and if they can do during the daytime, so it can be done. In my study in here, perform 30 deep breath once per hour when awake during the first 2 postoperative days, and it can be the 3 sets of 10 deep breaths over 15 minutes with the 30 to 60 seconds pause between each set.
So the patient should continue to do that for a couple of months, or how long do you think is it necessary to do this effective elimination?
Yeah, well, based on the study, we did not investigate until a couple months, but we only investigated after 2 days of the surgery. But based on the our literature, that there is no suggested exact time for exercise, but it is if the patient already be able to have good in respiratory, there is no signs of difficulty in breathing, or maybe they can have like secret or anything if they are get breathing, so no need to do that again. So it really depends on the situation of the patient, but we need to have like a more investigation on it for sure.
All right, thank you very much. I would like to open the floor for discussion if anyone in the audience has any questions from Dr. Suryanto. Anyone has a question? Hello? Does anybody have any other questions? It doesn't look like anyone is having any further questions. So I think the presentation was very clear, and the experimenter seems to have been very well organized, and it's a very meaningful and useful research that seems to help the bypass surgery patients. And thank you very much for bringing this to the attention. Yes,
thank you very much, Prof. Ranjith. Thank you.
Yes. I think we will move on. Do we have Dr. Lobna Mustafa in the audience? Dr. Lobna? Hello. Dr. Lobna, are you there? No? If Dr. Lobna is not there, I think we'll move on to the next presenter, Dr. Muhammad Ghazali Masuri. Are you there? Dr. Muhammad?
I'm around.
G012. Dr. Muhammad. Yes, thank you very much, Dr. Muhammad. I would like to invite you to start off your presentation, please, without spending time. Yes, you can start off with your title and please go ahead with your presentation, Dr. Muhammad.
All right, thank you very much. Okay, I want to minimize.
Okay. This is one of the recent study that we conduct related with mental health. Okay, this study is entitled The Development of environment, occupation, livelihood scale on workers' mental health status. So these are the group members. Actually, one of our collaborators is from Brunei. So Mr. Jairaju actually he unable to join us either online or offline. But of course, his contribution is very much appreciated in this paper. Oops. Okay. All right. So this is the content of my presentation for today. So briefly, I think I will share about the mental health issue related with occupation, and then I will explain about one of the model that we choose for the study, which is PEO model. And then I think it is quite important to look into the gap analysis, the methodology result, and innovation behind this study, which is the risk assessment matrix. And then perhaps at the end of the session, I will share some of the application and conclusion of the study. Okay, so as in the introduction, I think we believe that we spend about 1/3 of our daily life in work. Okay, so that's equivalent to about 8 hours a day. All right, from many studies, they shows that 1/3 actually affecting the other 2/3 of our daily life. So that is very important for us to identify what are the issue or what are the relevant information that is can be the contributing factors towards stress as well as other mental health issue among workers. So appropriate assessment, I think, is very important and should be conducted to assess what employment factors and the work environment contribute to this factor. Okay, so the purpose of the study is actually to explain the developmental process of the livelihood scale, which we call environment occupation livelihood scale on workers mental health status, or in abbreviation we call it LEO, and in bahasa Melayu we call it skala kemungkinan persekitaran and pekerjaan, or SKIP. Okay, so this assessment can be used to measure both of the factors on the mental health status employees based on DAS21 score. So there is a combination of well-established standard, well-established assessment which called DAS21. I think all of us is quite familiar with DAS21. And then the SKIP is a new assessment method that developed to analyze the findings from DAS. Okay, and later on we explain the risk metric table. So this is a new innovation from this research where we call it MH3, mental health hazard hierarchy, that will provide the vast opportunity for mix the mental health screening into meaningful output. So any respondent who has a QR code scanner, so feel free to scan the QR code at the bottom of my bottom right of my slide. Actually, that is the Bahasa Melayu version of the LEO assessment scale. Okay, later on, you may use the formula that I will share to transform your environment and occupation score into your stress level. Okay. Oops. Enter. All right. Okay. So this is a model that we chose. All right. So this model actually established way back in 1996 by Mary Law. She is an occupational therapist, and this model is called PEO, or Person Environment Occupation. Why we choose this model? So from many studies, we know that the contributing factor, or the three important elements that contribute to daily activities or daily stress, actually coming from the person itself, the environment, and the occupation. So in general, the personal attributes, the working environment, as well as the workload, all these three elements actually contribute to the psychosocial risk factor. Okay, so this is the gap analysis. Let's see on the right check box. Okay, so what are the current gap and the future, as well as the suggestion based on one of the model they call Nagler-Tashman model. Okay, we know that there's a lot of stress coming from workplace. Okay, those psychosocial hazard and the risk into this assessment is very much important to be understood, to be able to manage and to be able to measure the appropriate root cause of this particular issue. That's number one. Number two, in the gap analysis, they found out that implementation of collective preventive measure by adapting work organization and working condition. Okay, this is another important issue where many employer may take for granted the issue of mental health among their workers. Okay, they believe that their workers or their employees need to settle down their psychological issue by themselves. Okay, unfortunately, many of us, okay, in fact, fail to manage our psychological hazard at the workplace. That is the reality. All right. Number three, preventing occupational and other work-related disease as well as occupational injuries. We know that not only in Malaysia, in many other countries, they only focusing on physical injuries like fall, accident, and other physical injuries. But psychosocial hazard has been what we call it less been discussed, okay, in the workplace. So that is another important gap, an issue that need to be highlighted in the study. Number four is improving work condition and work organization. So we will discuss it later. Increasing the coping abilities of workers. Unfortunately, the company and the employer that we survey do not take any measures about coping abilities of their workers. So the current project, what we call it, activity do not show any roles and responsibility of the employer. Number six is actually building up social support. Okay, so in Malaysia, there's a lot of issue, lack of social support system. In fact, for example, if you have stress, anxiety, or depression, you may keep it silent. Do not share it with others because the tendency to turn that particular issue into something negative is much greater than to turn it into something supportive. All right. And number seven, assessing the needs of organization, individual as well as organization individual interaction. Okay. So workers had complained that they do not know where to channel their psychosocial issue in the organization, right? Okay, so this is another details of the mental health issue at the workplace, and I'm going to explain in brief, okay, the standard and legislation. So of course, I have lengthy information about this, but I will skip few of the slides and then we'll focus to the four critical issue from Malaysia context. Okay, the first slide is explaining the international issue. All right, so mental health at the workplace is a common issue, not only from Malaysia perspective. Okay, we can see that a lot of existing legal framework, even from Malaysia context or international context. And then there is a strategy to prevention. But in Malaysia, we are still lacking information with regard to the national legislation, regional standard, as well as international labor standard. Okay, and then global gaps and trends. So I'm going to share later what is actually the four critical issue from Malaysia perspective. I think I will go straight to the local issue. Okay, of course, there's a lot of findings and information about international context, but let's see what is actually happening in Malaysia. Okay, so there are four very critical from literature. They shows that four critical issue that need to be highlighted. First and foremost is about the low resources. Okay, if some of you have gone through the budget for 2022 in Malaysia, there's a lot of money spent on COVID-19. All right. Unfortunately, with regard to mental health, where mental health is a secondary issue due to the COVID pandemic, so the budget is actually less than 1% of the health allocation budget for mental health, and unfortunately, only one psychiatrist and one clinical psychologist for 100,000 of Malaysians. So the ratio is very worrying. So imagine that almost, I think every day we had the the negative or the issues related with mental health in Malaysia, but we only have the ratio is 1 to 100,000. Okay, so that's number one. Number two, there is uncertain of where and how to act. Okay, so most resources actually, as I mentioned earlier, is focusing on COVID-19, including the vaccination. Okay, billions of it goes there. But mental health care services still limited. In fact, some of the services is reduced due to the SOP and all the stringent kind of thing have been introduced lately. Okay, another issue is poor geographical distribution of psychiatric services. So not all facilities actually provide psychiatrists and clinical psychologists. You may go to the state hospital or general hospital. So unfortunately, people with mental health issues is available almost everywhere and anywhere. All right, that's number two. Number three is about the stigma. All right, and the stigma in Malaysia is also something that is very significant due to the mental health literacy. All right, some people believe that when you talk about stress, depression, anxiety, for example, it strongly relates to gila or something that is insane in a bad word. All right, so the literacy and education is still very not to say poor, but need for further action. All right, so only 1 out of 5 Malaysians who have mental health condition receive treatment. So what will happen and what happened to the other 4? All right, so only one. So they cannot identify sign of poor mental health, and sometimes the employer may relate it with the association of laziness without knowing the root cause why they shows the laziness sign and symptom at the workplace. Okay, and the last one is productivity cost. Okay, there's a lot of issue about absenteeism. Some of them may present but unwell during work time, and staff turnover, employees might be tempted to hire only healthy workers. That is also another stigma issue, right? Okay, so the methodology, all right. So the first phase, actually, we conduct the triangulation where we examine the written evidence, the publication, and then we conduct an interview with expert, and then we collect all the information and develop our questionnaire. All right. So the major references for our questionnaire is actually from international labor law. I think people who are in this industry should be familiar with ILO 2012, where this is a set of documentation to explain the international labor law about the workers and the employer and the employees. And then there is another literature that we refer is Cox et al. 2000. All right, from there we communicate with 23. In fact, we communicated with 30 panels. Only 23 of them responded to our survey, and all of them has vast experience in terms of occupational safety and health, occupational health doctors, psychologists, clinical psychologists, and psychiatrists. Oops. All right, okay. So when we finish with the questionnaire, we survey the questionnaire first, and we managed to get 277 participants who participate in this pilot stage. And then, of course, the female is dominating the survey with 208, followed by 69 male. So from this study, we managed to extract 10 questions. Okay, this is where we call it Leo. All right, and the content and face validity is considered high, 3.6 to 3.82. Okay, and then the values later on translate into the likelihood scale, which I will share later. Okay, I think this is just an explanation about DAS. Okay, DAS is used as an independent assessment. Okay, so SKIP will be dependent, DAS will be independent. And the beauty of this formula is actually any mental health assessment or screening who has 5 Likert scale, 5 Likert scale can be used with our formula. Okay, for this study, we specifically use DAS 21 because this is commonly used by Ministry of Health Malaysia and many other peoples in Malaysia. It's something that is well established and can be understood very well. Okay, so DAS is an independent assessment for this study. Okay, So this is we conducted using an online survey. So that one is that's an official Department of Occupational Safety and Health website. Okay, so this study is actually supported by Ministry of Human Resource. So we have the Bahasa version and English version. Okay, but for Bahasa, you can just use the QR code at the bottom right of my slide. Okay, so the result, we managed to collect 865 employees who participate in this screening program. So from that value, we got L, which is likelihood, S is severity. Okay, and then we transform it into MH3, mental health hierarchy, hazard hierarchy. And this one was adapted from Masuri's previous study in 2020. Okay, so this is the result. So male 333 and female 532. Let's see how many of them is actually income category. So in Malaysia, we have this kind of code, B40, below 40, middle 40, and T is top 20. I can't remember the salary, but actually the majority of our respondents is coming from middle class, M40, 258 respondents, equivalent to 48.3. Okay, 208 of them are singles, majorities are married, okay, and divorced as well as others. So we have another 5 questions from this particular study to measure the effect of COVID-19 towards their mental health. We can see it's quite balanced. COVID-19 giving contribute to mental health issue. It's about 48.7 believe that high impact of COVID-19. Followed by 49.3% claim that COVID-19 effect on their financial issue. Okay, high. And then another one, 43.8%, equivalent to 284, said that COVID-19 effect on their work productivity. And then 45.9% believe that, claim that COVID-19 effects on their social activities. And the last one, 39% claims that COVID-19 give a negative effect on their overall quality of life. Okay, even though it's not exceeding 50%, but I think that figure is something that we need to look into further. Okay, so about the sector, the majority of the respondent is actually from public services. Okay, 80.2%. All right, so we can see that it is not normally distributed, or however, from our findings, the DAS score, DAS 21 score, shows that there is not much different. Either you are coming from manufacture, mining, or any other sectors. Okay, the level is quite significant. Okay, so this is a DAS 21 score. Okay, you can see that the 3 red circles. Okay, that one is severe and very severe. So to be honest, according to Ministry of Health framework, people who score severe and very severe, they need to refer to psychiatrists or clinical psychologists. So we can see that, okay, for depression is more than 100, of course, anxiety is more than 200, and then only stress is 80%, 80 respondent, 60 plus 20. But in overall, we can see that the numbers of people who require for assistance is quite high. Okay, this is the history of mental health hierarchy hazard. Okay, if any respondent who managed to fill in the survey, so you can see that on the left column, Q1 to Q5, you can what we call it, add all together from question 1, 2, 3, 4, and 5. If your score fall under, between 5 to 8, so that shows the likelihood of your occupation is less contributing to your depression, to your anxiety, to your stress. However, if your score is more than 19.5 or 20, then we believe that your occupation is the contributing factor to your current depression, anxiety, and stress. Okay, so you can only experience it when you fill in the assessment form. Later on, we will transform it into apps, but not yet. And then the bottom one is the environment. How much is your working environment contributing to your depression, anxiety, and stress? If your score fall between 5 and 6 again, so that means your working environment is good. It's considered as good. But if your score is fall between 21 and above, so there is something wrong with your working environment. Okay, your working environment can be found to be as the most likelihood to contribute to high amount of stress, high amount of depression, and high amount of anxiety. Okay. Okay, this is how it works. Okay, this is the secret recipe. All right. So when you get the DAS score, you need to use this formula, and then from there we can get the color coding. Okay. So we are expecting people who fall between green and yellow. All right. But don't be surprised that from other studies we found out that people who are as a frontliner and educators, okay, they got many scores fall under the red category. Right. So including lecturers. All right. Very stressed. Okay. Working from home, working from office, and then keep changing the policy and everything. All right. Okay. So this is more explanation about the how we formulate the traffic light or the colors. Okay. So this is the guideline from Ministry of Health. If you fall under the category of red, so you what you need to do? You need to be referred to clinical psychologist or psychiatrist. Okay. So imagine that. All right. Yellow and green can be considered for what we call it in-house intervention, but red you need to be exactly you need to refer for hospitalized. Okay. In conclusion, just to mention to others, so this is the current document, ISO 5003, 2021. So there is a new guideline just coming out June this year concerning about the psychological health and safety at workplace. So this study is aligned to the current ISO document just released. Okay, so this is one of the world interest nowadays about the mental health at the workplace. So from this study, we believe that top management needs to play their important roles. That means, for example, if we have the bosses and all those things, so they need to focus on the mental health issue among workers. So the effective management of psychosocial risk within a workplace requires for clear roles, clear support, as well as responsibility from occupational health and safety, including the OHD. All right. The number three, the organization should promote and support. So in Malaysia, I think one of the issues is education, lack of promotion, lack of support. Okay, about this issue. And the last one for my presentation, okay, we believe that organization should consider the following issue. Okay, first, psychosocial hazard. From nowadays, I hope all the employer will start to look into the psychosocial hazard among their employees. All right. Prevention of injury and ill health is similarly important as psychosocial hazard. Strategies for workers returning to work. For example, we just end our pandemic, so the return to work issue, opportunity for improvement, as well as improvement of the current safety system in Malaysia. And finally, the organization should prioritize action based on its assessment of psychosocial risks. Okay, so I think with all that, this is the acknowledgement. So this study is funded by Department of Occupational Safety and Health Malaysia under the JKKP 07221 MD grant. All right. So thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Mohammed, for that very interesting presentation about the issues of mental health in the workplace. I think we are all very familiar that this is a universal problem that exists, and I believe it is the case in Malaysia as well as you presented. As you said, there are three factors in this equation, isn't it? The personal attributes of the individuals, the environment, and the workload that comes into being. While you also said that the attention to resolving mental health issues of this nature is very, very minimal, and you said that there are only one psychologist for 100,000 population in Malaysia, which seems to be completely unacceptable and inadequate. Um, I wanted to know what exactly do you think does environment play a role in this case? We understand that the workload is excessive, and that is something that the organization may need to manage. But in terms of environment itself of the workplaces, which aspects do you think have the most important impact on mental health issues of the workers? Would it be possible for you to elaborate on that from this study? Environmental aspect.
All right. Thank you very much, Prof. About the environmental factors. So, in fact, from our study, we found out that there are 5 important environmental factors that is contributing to stress, anxiety, and depression. So, one of it is I try to find the best points. Actually, one of the environmental factors at the workplace is including the what we call it tools maintenance and tools availability. Okay, for example, few respondents who respond a high amount of stress working from home is actually due to the lack of the ICT equipment. So that is an example of environmental factors contribute to high amount of stress. Okay, they need to share their mobile phone with the family members. They are having the internet issue. So that is one of example environmental factors in this particular study. So there are another 4, but I'll just explain one where there is what we call it aligned with international labor organization document. Yes, Prof.
Thank you very much.
All right, thank you very much, Prof.
Sorry for the technical issue.
I was saying that one of the issues is that there is stigma attached to it, that people are unwilling to accept that you are suffering from many mental stress and things like that. And on top of that, there are no visible signs often
Okay.
until things become actually serious. So I was just wondering, what can the individuals themselves do at the very initial stages of mental stress that prevails before it
Okay.
gets to the
So what
organization? Yeah.
I think what we are suggesting from this study is actually to conduct a screening assessment for all
I see.
employer to identify their current state of mind among their employees. So that will
I
be a
see.
new policy. I think there will be a new policy by the ministry to make it compulsory to monitor, to assess and to screen the current state of their depression, anxiety, and stress among workers. So from there, I think the ministry or the employer uh, will take further action. Either they fall under the category of green, yellow, or red. So in fact,
I see.
if the respondent fall under the category of yellow and red, they need to communicate with other parties, which is usually under the Ministry of Health. So they will pick up the case later, Prof.
Is it possible that if someone falls into the red category, that the person could be sacked from the work because he's not mentally fit? Is there a
Okay.
danger?
With regards to that, I think the stigma, some of the, not some, I think majority of us is quite worrying to declare that we have an issue. However, it is not a simple, it's not a simple process to terminate others from services unless he has undergo all the process, including the medical board. And to be honest, all workers should not worry, even though if they has a sign and symptom of the mental health issue.
Sure. Yeah, this is a very sensitive issue.
Yes.
I would like to open the floor for discussion if anyone has any questions or observations from this wonderful presentation. Is there anyone who wants to raise a question or make any observations from the audience, please, and the listeners of the digital system? Anyone has a question? I don't hear anything, so I assume there are not many questions. Your presentations was very,
Thank
very
you very much,
comprehensive,
Prof.
and it was very clear. And thank you very much for
Thank you,
bringing
Prof.
attention to the issue of mental health in the workplaces and the stress that arises from there. I think we will move on to the next presenter. Is Miss Fatima Najiha Bedrul Alam present in the audience? Miss Fatima? Yes, Miss Fatima, could you start your presentation, please?
So good afternoon, Assalamualaikum warahmatullahi wabarakatuh, everyone. My name is Fatima Najiha binti Badrul Alam. Today, I will present my study entitled The Impact of the COVID-19 Pandemic on the Dietary of Malay Hypertensive Patients. So here is my content that I will be present today. I will move on to the introduction. So, uncontrolled hypertension can lead to coronary heart disease and stroke by damaging and weakening blood vessels, causing them to narrow, rupture, and leak. So, without proper treatment and management, the hypertension may lead to death. Therefore, it is important to comply with both pharmacological and non-pharmacological interventions, which will help to reduce the blood pressure levels. So the non-pharmacological interventions may include physical activity, dietary management, smoking cessation, and also weight management. So nevertheless, in response to the COVID-19 outbreak, so several countries, including Malaysia, implemented stringent measures, including physical distancing or lockdown to curb the virus infections. So in Malaysia, our country, a movement control order (MCO) has been implemented. Hence, there are more people spend more time inside and have limited physical activity, which may indirectly influence their dietary habits. So this massive response to the COVID-19 may have jeopardized their routine treatment frequently needed of the hypertensive patients, as the number of clinic visits for NCDs patient continues to decline and also postpone. So this circumstance may have resulted in inadequate patient care maintenance, which resulting in a poor quality of life. So according to World Health Organization, WHO, one of the aspects incorporated in the domain environment for overall quality of life and general health is the opportunities for new information and skills. So patients with hypertension may experience a decrease in their quality of life as a result of limited access to knowledge and skills, particularly nutrition education. So in addition, the stay-at-home circumstances may restrict their physical movement and daily intake of an individual, which may have a significant impact on their dietary management among hypertensive patients. So in Malaysia, we noted that there is no study has explored the hypertensive patients' experiences of dietary management during COVID-19 and how they deal with the circumstances. So we move on to the problem statement. So this circumstance may have resulted in inadequate patient care maintenance, resulting in a poor quality of life. I'm sorry. So the enforcement of Movement Control Order (MCO) by the government of Malaysia is to help to counter the COVID-19 pandemic since early 2020. So which then resulted in the restriction of unnecessary activities outside the home. So this stay-at-home circumstance may restrict the physical movement and daily intake of individual, which may have a significant impact on their dietary management, especially among hypertensive patients. So thus, this is very crucial to explore their dietary management, which leads to our objective is to explore their experiences in dietary management during this period of COVID-19 among these Malay hypertensive patients in Malaysia. So let's move on to the methodology. So in this study, a phenomenological approach was implemented. So this study, we use purposive sampling to recruit a total of 14 participants that meet inclusion and exclusion criteria. So here are the inclusion and exclusion criteria. For the inclusion criteria, the patients must be Malay, aged between 18 to 39 years old, and has been diagnosed with primary hypertension, willing to participate, and also computer literate. And for the exclusion criteria, the exclusion criteria is patient must not be from secondary hypertension, suffering from any mental health, and also doesn't have any physical disabilities. So here is the procedure of our data collection. So patients that meet inclusion and exclusion criteria during the screening process was contacted via phone call or WhatsApps to be recruited and get consent. So the data collection process was performed by two methods. First is to face-to-face interview at clinic, and second is online video using Google Meet or phone call interview, which is during the period of CMCO and MCO 2.0. So the interview took place between September and December 2020, and duration of each interview took between 20 to 45 minutes to complete. So all the conversations during the in-depth interview were transcribed verbatim into Bahasa Malaysia while we listening to the audio tape. And the textual data after being transcribed were explored using the content analysis method according to Corsian MOC 2018. So during the analysis process, numerous codes were identified and relevant codes were categorized under each code by it was assisted by Atlas DI software. So here is our strategies to ensure the trustworthiness in validating the data, which include prolonged engagement, methodological triangulation, persistent observation, data triangulation, and peer debriefing. So we move on to the results and discussion. So based on the dietary experience among the participants, our result highlighted three themes, which include no changes, improving diet, and also worsening diet. So majority of the participants, 79% of them indicate that they had improved in their diet or habit throughout the COVID-19 pandemic. And this represented by 7 sub-themes, including portion control, cooking at home, proper meal timing, low salt diet, self-control, less eating outside, and also fasting. So while the rest of them highlighted that they are experience in worsening their diet or habit, and also there is no changes at all as they may eat the same as usual. So 9 of these respondents agreed that this pandemic situation had led them to start cooking at home. So these changes in dietary consumption can be attributed to either a willingness to improve one's diet or to a disruption of eating habits caused by the temporary closure of restaurants or the restriction of operating hours. For example, as you can see here, participant 002 mentioned that in terms of his or her dietary intake during the pandemic, they were unable to buy food outside due to restriction ordered by the government. Hence, if they really want to eat specific menu, either they need to cook or they don't eat. It's either one. So meanwhile, participant 028 mentioned that we do crave for fast food or restaurant meat, but all the restaurants are now closed. So as a result, they need to eat at home only. So next, participant 003 also mentioned that he or she started to cook at home rather than eating out, and he or she also highlighted that he was buying air fryer to assist them in the kitchen. So they learned a lot of new things like cooking by their own. So the rise in this results is actually consistent with previous research from Hussain and Ashkanani 2020, underlined that there was a significant increase in dietary habits among adults living in Kuwait during COVID-19. So their findings reveal that the percentage of people who cook by themselves increased during COVID-19 when compared to before COVID-19. So the rise in home cooking could possibly related to the attempts to occupy their increased free time, which resulting from the quarantine. Meanwhile, according to Su et al. 2020, the COVID-19 pandemic impacts such as epidemic concern, impact of psychology, impact of work or study has been also associated with a higher score of willingness to adopt a healthy dietary habits. So in contrast, our current study also discovered that some participants experience worsening of their dietary management, including poor food choices and also overeating throughout the pandemic. So, for example, participant 025 mentioned that my children occasionally enjoy sugar-sweetened drinks such as tapioca milk tea or boba milk tea. So, of course, he will join them in drinking. Meanwhile, participant 016 also mentioned that staying at home make both me and my children hungry. So, if they say I'm hungry, I will cook whatever they want. So, of course, I will eat together with them. So, meanwhile, next, participant 025 also mentioned that whenever we ate together, I had to finish all the food that my kids did not. So this situation actually could arise as a result of spending more time at home and being influenced by other family members. So Radwan et al. 2020 reported that the most prevalent unhealthy change in behavior among participants was an increase in food intake, which could be contributed by irregular eating patterns and frequent snacking. So the researchers proposed this situation as emotionally induced eating, as it could be driven by the feelings of fear, anxiety, anger, and also stress during the confinement process. Similarly, another study conducted among Danish population revealed that an increase in emotional eating, which may be a result of the stress and boredom associated with the lockdown, which caused them to snack more frequently and consume more food during the lockdown period. So, in conclusion, we found contradictory changes in the dietary practice as a result of the pandemic situation. So, correspond to other reports of changes in dietary practice during the lockdown in other countries. The findings of our study reveal the improvement and worsening in dietary management, as well as no changes in some particular individuals. As the COVID-19 is still spreading globally, which may have a lasting effect on lifestyle-related behavioral changes, this may have implications on the quality of health. So therefore, it is important to have an alternative solution to acquire knowledge during the pandemic, apart from relying solely on the clinic appointments. So I think that's all for my presentation today. We hope this research will give a big contribution for health practitioners as well as hypertensive patients. With that, thank you.
Thank you very much, Ms. Fatima, for that interesting presentation about the impact of COVID-19 on the dietary habits of hypersensitive patients. And you adopted a very interesting phenomenological research method also to try and figure out what's going on with the COVID-19 patients. I have two questions. COVID-19 is a very specific situation that has lasted during the last 2 years, of course, and it is going to change. And now the disease has spread and is under control with vaccination. The habits that have come into being as a result of COVID-19 are unlikely to continue, although you were concluding that the changes of behavior may last. So this assumption is to some extent questionable, because like you were saying, they were stuck in home and food was not available, fast food restaurants were closed and access to food was limited. Children were at home, they were hungry, and you cooked and you partake. These are going to change invariably. These will change because the pandemic has sort of come to not continue. This is one assumption. I'm just raising the question: is it correct to assume that the dietary habits will continue to follow what came into being during the COVID-19?
Okay,
Is it fair to make that assumption that it will continue? Because the whole situation is going to change and behaviors are going to change.
Okay.
What do you think?
Thank you for the questions. So yes, it's true. And nowadays, we can see that the numbers are going down. So because we have vaccination and so on, and all the economy start to some restaurants are start to open again as usual. However, we still didn't know how this situation might be in future, which means so because this COVID-19 suddenly came to us and we are going through the lockdown. However, we have lots of variants and so on. And yes, this happens in this some period, and this is why I come out with not a solution, it's just a suggestion that we need to have an alternative solution for these patients, because as we can see now at clinic, there's the clinic appointments are still postponed, and because we are still they still want to have physical distancing at clinics and also hospital. So not everyone can came as usual as before. So so patients might have some difficulties to communicate with their healthcare providers. Therefore, we provide a suggestion, also alternative solution, that we need another solution, such as, for example, for my own suggestion, we might need from we might need to have online consultation, or we need to have a patient education website that can assist patients to learn how to manage their disease. So which can make benefits in future apart from in this COVID situations only, because in future there might be a new virus came or a new situation that can come later on.
Right.
That's my
Yeah, thank you. But the other point that I wanted to pick up is the suggestion that you're making in terms of an alternative solution. Now, dietary practices are very personal, individual, and not necessarily institutional. What alternative solutions do you have in mind? I mean, is it possible for organizations outside the family and individuals to try and interfere into the dietary habits of individuals, even though they may be hypertension patients? Is it possible, you think that? And what are the alternative solutions?
sorry, can you repeat the question? So not clear.
There are two questions there, really speaking. One is, you are suggesting that there should be alternative solutions. And when you suggest alternative solution, you are implying these alternative solutions may have to come from outside agencies. Now, my point is, dietary habits are very personal and individual. I mean, you cannot go and sit at the dining table and tell the people what to do and what not to eat and things like that. So it's very individual. Is it possible for external agency to intervene into this and make any changes in the dietary habits? Is it possible, you think?
Okay, thank you for the questions. So actually from our previous from previous studies, there are lots of new and alternative solutions that come out during this COVID-19. Actually, there are a lot of studies that come out with telemedicine or online consultation during this COVID-19 period. And actually before this, we also have this telemedicine, but it's not common yet. But now I found a lot of studies that have in other countries that have implemented telemedicine in their practice. So so this telemedicine is might be the one of alternative solution that we can use to in our community here. However, this probably not suitable to all age. So as you can see, hypertensive patient, there might be people in between 20 to 45. There might be people above 60. So maybe those who are required, or they don't, or we call it a computer illiterate, who are unable to use technology as young people, they need to attend our clinic as usual. However, for those who are able to use technologies and also is computer literate, we can actually use this telemedicine to assist them in helping them manage their hypertension management, in terms of maybe for example for dietary management. So for example, for the this is an example. For example, for the first appointment, for one of the appointment, we might teach them on by using patient education website. So we might teach them assisted by education website. So then in future or the next time they want to refer, they want to know more about their management, they can refer to the website. So that is other examples of alternative solution that I suggested.
Thank you very much. I would like to open the floor for discussion if there is anyone in the audience who wants to raise any questions or make any observations. Is there anyone? Dr. Suryanto, maybe you want to say something? No. I do not hear anyone wanting to raise any questions. I think the issue is very clear and you made a very nice and interesting presentation. And I think the idea of alternative solutions seems to be very meaningful as well, although I was questioning the assumptions there. Thank you very much indeed for that wonderful presentation. COVID-19 is a very unique situation. And what this shows is that people have not abandoned those hypertension patients, even in the situations of COVID-19. That is a great facet of the contemporary society in which we live. And we are very, very fortunate to be living in this society which cares about people, even in the worst kind of scenario. Thank you very much.
Thank you. Thank you for your time.
We will move on to the next presenter. If Miss Noraslina Jazli is in the audience, please. Miss Noraslina.
Hello, sorry, Professor.
Yes, please.
Yes, if I may I let Lobna, Dr. Lobna, to present, because
Lobna is present. Yep. Okay, that's fine. Yep. Okay, Ms. Lobna, could you start your presentation, please?
My research paper actually is about the impact of investigating the impact of quality of life program on public spaces, and the case study was in one neighborhood in Riyadh, the capital of Saudi Arabia. The research, this presentation contains the introduction, objectives of the research, methodology, followed methodology, survey results, conclusions, and recommendations. As we all know, that quality of life has become one of the most trending subjects for over the past maybe 15 years, for the reason that the community and the members of the community need to feel more satisfied and more happy within their built environment. The quality of life factors refer to many issues, which we are going to see today. But the most focused part of this research actually is the built environment and the open spaces in particular, and how they affect the perception of the person for his own quality of life. The objectives of this research is there is two concepts that are central to this research: physical activity as a part of everyday life, and the built environment, outdoor public spaces. Accordingly, this paper provides insights on the importance of the social urban dimensions of sustainable public spaces based on visits to one of Riyadh neighborhoods and a survey of the residents of Al Falah district in 2021. The following underlying questions guided the research. How did the city of Riyadh establish social dimensions of neighborhood development into the redesign process of Al Falah to achieve sustainable communities and the quality of life goals? And how do the residents perceive this level of quality of life throughout the physical settings and the social engagement in the selected neighborhood, of course, and they are satisfied with their well-being? The structure of the research went through 4 stages. The literature review, which discussed mostly the quality of life and in particular in neighborhoods. The descriptive analysis. And the descriptive analysis, actually, it was for the project of reviving Al Falah district and enhancing the urban quality of the public spaces. Then the methodology and the survey results, followed by discussion and the conclusions and the recommendations. As we all know, the quality of life program, as I have said, that it is not a new topic. We actually have this series of quality of life conferences, which I am really happy to join for the 3rd time. And it's always discussing how the community members perceive their...
Ms. Lobna, are you changing the slides or not? Is it not moving?
I am changing, yes.
It's not moving. Maybe you're not sharing the... Yeah, now moving. Okay, now.
You didn't see the previous?
No, previously it was not moving. It was on the first slide.
Thank you for telling me. Okay, I went through this one, then the content of the research. Then the main focus of this research is the quality of the open spaces in the built environment.
Yep.
Then the objectives of the research. Then the structure of the research. And we are now here within the quality of life.
Okay, thank you. Please go ahead.
So quality of life in communities and cities, as we all know, I think we all know, it's related to some main fields. Most of them, or all of them, surrounding a person. One of them is the built environment. The other one is the social factor, then the economical factor, and the environmental factor. All of them together are shaping the quality of life of each individual. So Saudi Arabia here, they launched their national vision, Saudi Vision 2030, back in 2016. And this vision is actually very inspiring because they are trying to enhance the people's life in many, their country life in many ways. But the thing that captured my interest was the Saudi quality of life program. This program is part of, it's actually the application part for the Saudi vision. The quality of life program was launched back in 2019, and the quality of life of neighborhoods, it's launched in 2020, last year. This program, the Quality of Life program, focused on two main objectives: improving individuals' lifestyle by developing new approaches that boost residents' participation in culture, entertainment, and sports activity, and enhancing the quality of life by creating activities that are contribute to diversifying economic activity and boosting the status of sustainable development plans of Saudi Arabian citizens. Here are the metrics for this quality of life program. The quality of life program actually identified all factors that contributing to the quality of life, which are the economic factors, the activities of the people, the entertainment, the transportation, education, housing, culture, and heritage, social security, infrastructure, community engagement, health, and sports. The ones that I am surrounding by this blue lines are the ones related to the built environment and public spaces. These factors was driven from 6 main international indexes for the quality of life. For example, the European Union, they made their own quality of life index. Then the OECD, they made their own quality of life index. So by analyzing these quality of life indexing, these are the main factors affecting the quality of life according to this index. Some of them are missing some and focusing on others, as we see, but the main factors related to urban environment and public spaces, we can see now by eye that they are the most common between all of them. So let's move to the other part of the research, second part of the research, which is the case study of Riyadh neighborhoods. Sorry. Okay, it is a case study of Riyadh neighborhood. The Riyadh neighborhood project is called the Humanizing Neighborhoods Initiative. Humanizing Neighborhoods Initiative is part of the Quality of Life program, which I just presented. The main goals of this initiatives are raising the quality of life in the city of Riyadh till reaching the boundaries of land plots in the residential neighborhoods, contribute to the normalization of cities in Saudi Arabia and the city of Riyadh in particular, which is the capital of Saudi Arabia, maximizing the economic benefit from Riyadh mega projects, improving the urban visual image and the urban design, and enhancing the level of satisfaction and the safety, of course, for the neighborhood residents. These photos actually is from this humanization of neighborhood manual. The Al Falah district, it was chosen along with another district, which is Rueha, as a pilot study or the pilot project for this initiative, meaning that starting from January 2020, these both districts was under urban enhancement for all their public spaces as the main or the pilot projects. According to the results, they're going to generalize the same initiative for other neighborhoods. As we see how the status of the street was and how they are designed to be. It's actually still undergoing now. It is not finished. So the neighborhood that I chose was El Falah. This is the location of El Falah in Riyadh city. Actually, El Falah is in the northern part of Riyadh, which is the most developed part of Riyadh actually. And this is El Falah, the northern part of Riyadh districts and the neighborhoods. It's following docked squares with almost 2 kilometers by 2 kilometers, and all of them is distributed into 4 neighborhoods, with a general mosque here, which is Jama', and a small other masjid in each neighborhood, and the neighborhood garden. There are many streets, 4 main streets, then the internal streets. So the Riyadh Municipality Program for the Development of Residential Neighborhoods is a part of a significant initiative in the city to achieve the goal of quality of life program of the Saudi Arabia. The program is one of the fundamental pillars in humanization the city and making it more suitable for humans by applying the standards of sustainability and comprehensive accessibility, and raising the levels of safety and security in the urban context that achieve both function and beauty. It also promotes traffic safety and the hygiene system, and organizes public spaces by linking the pedestrian network to public utilities and public stations, and allocating parking spaces for vehicles, bicycle passes, and walking movement streets. The main 4 streets here are the main mixed-use streets, while all the internal areas are residential only. So we can see here how this project is intended to be. Here we can see this is Al Falah district. These are the main passes for the pedestrian of Al Falah. While the project is intending to provide main pedestrian walkways with the very wide sidewalks for pedestrian, and the small passes for busways for scooters and bicycles. The methodology followed for this research, the data presented and discussed the following. Section was collected through structured survey conducted in Al Falah over 3 weeks in November 2021. This period was selected as one of the mildest weather in Riyadh throughout the year. The temperature is an average of 30 to 26, which is almost 12 degrees lower than summertime. People usually go out more frequently than in the rest of the year. Participants were asked to fill out a survey instrument containing 27 mandatory questions and 1 open question. 70 completed survey were collected as a representative sample for obtaining insights and observation about the targeted population group. All respondents were at random, and the responses were voluntary with complete anonymity. The surveys were either filled out with the collector, with myself, or presenting with the people, like an interview on the street, or distributed directly with the resident or people working in Al Falah. It was a link to Google Docs, which I sent to people either by their emails or WhatsApp, or by meeting them on the street. Characteristics for the surveyed population: 60% were female and 40% were males. The main age group was the people from 21 to 30, then people from 31 to 40, 41 to 50, and 15 to 20, then other age group, including some children. Okay. Here I asked the participant about their status of resident in Al Falah. Almost 70% of them are Falah resident, while others are 30% regular existing in Al Falah in a regular basis, either because they are working here or because their families are living here. For the resident, most of them were resident in Al Falah from 3 to 5 years, because this is actually a new district in Riyadh. And the list of them was less than 1 year. Some of them were less than 1 year, and some from 5 to 10 years, and the few from 10, only 11% from 10 up to 15 years. Survey results and the data analysis. As I have mentioned, I asked that it was both in Arabic and English, because Riyadh, as a city, is a cosmopolitan city with many citizens from other nationalities. So I distributed in both Arabic and English. I asked the participant about how frequently they go out in public spaces in Al Falah, how frequently they are using vocabulary as the main way to reach their daily needs within the district itself. And I asked them about their main district within Al Falah. And as you can see, for the majority, going to school and going to the university, because there is one big university in the district, for the majority, this was their destination, followed by going to work, then going to daily needs like grocery, pharmacy, laundry, stuff like this. And 25% their outing was for the district or the neighborhood garden, or for visits. Some of them was for jogging or walking within the street, down the street. Most of them were going out alone. 50% of them, 55. Then 51 is the family. Then 7% is the group of families. Then 20% with their friends. As we can see here, their evaluation of the participant evaluation for elements of public spaces in Al Falah. If we took it by grading, by ranking, they felt that the sidewalks is the best satisfying for them, because it's now wide and they can walk safety. Then the pedestrian safety, because this is affecting this actually. Then suitability for elder and people, for elders and people with disabilities or special needs. Pedestrian crossing, they was satisfied about pedestrian crossing. Then comes in the following ranking, street signage, garbage containers, and their list satisfaction was regarding street furniture and trees and plants. And actually most of them commenting that there is no sitting furniture within the street, and also there is a very lack in trees and plants. Evaluation of public space development impact on people's quality of life. They were asked how they feel this is affecting them. The wide sidewalks encourage more walkability. I was asking them in a Likert scale of from 1 to 5, where 1 disagree and 5 strongly disagree and 5 strongly agree. The first one was wide sidewalks encourage more walkability. Scooters encourage more outings, because now there is electronic scooters along the whole district. Public space development encourages more social activities. Public space development enhances the visual image. The public space development enhances safety, enhances quality of life inside the district. And the last one was actually very important for me. It was asking the participant if they would like to take place and participate in this project. As we can see, most of them agreed that the public space, the public spaces development project, which is undergoing now, is enhancing their quality of life. Then it's enhancing the safety and enhancing the visual image, and encouraging more social activity. While less of them they were less agree on scooters encourage more outing, and regarding how they would like to participate in public space development project, I think this ratio is still good, very good, and it's here the mean is 3.86, and we have almost 50% agree, strongly agree, 47 strongly agree to participate in this project. Community engagement and participation is one of the pillars of quality of life worldwide, and one of the pillars in the program here in Saudi Arabia. Conclusions and recommendations. Public spaces in the cities are the drivers for sustainable change and social cohesion. However, while streets usually account for 80% of public spaces and parks and gardens are only 20%, pedestrians are legitimated road users, but they are frequently overlooked in transportation system. Considering the need for walkability through transport planning, like reducing traffic speed, providing more streets furniture, can encourage more pedestrian and impact the traffic safety. More people walking also provide more eyes on the street, which enhances the sense of safety, and they may also contribute to the crime reduction. More people walking creates more activity and opportunities for social interaction, which helps prevent loneliness and stimulate social cohesion. Improve the conditions for active mobility are one way of addressing inequity. Encouraging active mobility and reducing motorized vehicles has a considerable positive impact on pollution, reducing travel times in neighborhoods, and restricting parking help improve pedestrian crossing and provide better connection to the gardens. Recommendations, the research providing recommendation in 3 levels. For the institution level, the need to activate the role of NGOs that encourage volunteering, and this will fuel the development of non-selfish involvement of the young generation who might be unemployed, and getting them volunteering can open up employment doors and also help get necessary work done. For the urban level, public space provides unique opportunity for interpretation and the education of natural values and the community history and the culture, including the physical and the social activity. And the Falah project presents an excellent opportunity for a best practice if the community feedback was put into concern. For the community level, it's highly recommended to investigate engaging local communities in place-making projects on the neighborhood level. Finally, I'd like to say that people, when feel that they are important to decision makers and their opinion matters, it will motivate them to take actions and start developing their neighborhood by their own as a community. And this example in particular support that people are willing to improve their own neighborhood by their own. Thank you very much.
Thank you very much, Lobna, for that excellent presentation on the impact of quality of life programs on public spaces in Riyadh. You gave a wonderful example of how the city has been transformed and how it has impacted the quality of life of the people in that city, and the ways in which the public would participate in the improvement of their neighborhoods if they feel that they are being recognized and they are being afforded the opportunities to do so. Now, your focus was, as I could gather, was on the pedestrianization and sidewalks.
Pedestrian and the sidewalks, it was focusing on considering walkability as an everyday habit.
Yeah, right.
Not only for people that want to have fitness, but as an everyday habit, so people can go out and manage to meet each other and have more social connections. And surprisingly, this is works really for many people because of
given the harsh climate in Saudi Arabia and the dependency on motor cars, trying to
it's important to have this street furniture, like having sitting areas for people and having some shading devices, for example.
Trying to encourage people to walk is a tremendous effort. It seems to be succeeding quite well. I was just curious whether there are other aspects of quality of life improvement other than the sidewalks and promotion of walking. Are there other things that are being done in Saudi for improving quality of life in terms of environmental improvements?
Sorry, I didn't hear the
question. I was just curious whether there are other quality. You talked about quality of life program. I'm sure quality of life program does not involve only pedestrianization.
Yes, as I may brought again this slide. The quality of life program in Saudi Arabia actually is tackling all of these: transportation. Can you see this slide? It's transportation, entertainment, activities, economic, education, housing, culture and tourism, social security, infrastructure, community engagement, health and sports. There are different projects or different programs for initiative for each of these pillars of quality of life. My main focus actually was the one regarding enhancing the quality of life of neighborhoods to enhance people lifestyle and in making or transforming the community from a vehicle community to pedestrian and more physical active community.
Great.
Because this is mostly focusing on my area of specialization, which is urban design.
That's great. Are you teaching at the university in Saudi?
Yes, I am now in my office in the university, and my students are waiting in the studio.
Oh, great! Yes, I'm talking to you from Bahrain, by the way, your neighbor.
Yeah. Yes, from Bahrain. Yes, I read it within your title. Yes.
Yeah, great.
You are a neighbor here. Comparing with Malaysian friends, you are a neighbor.
It's a very interesting connection. Anyway, thank you very much for that wonderful presentation on the quality of life on the sidewalk improvements in Saudi Arabia, and it makes a lot of sense as to how we can contribute to the improvement of quality of life through architecture and other means in public spaces. Thank you very much indeed. I wonder if there are any questions from the audience. Anyone wants to raise any question or make any comments from the audience or listeners? I don't hear anything. I think most of the participants here are from different disciplines, particularly in the medical, mental science, and so on. And you're the only one from architecture and urban design. Nevertheless, thank you very much indeed.
Thank you. It was my pleasure. It was my pleasure being with you today. And I wish I could stay, but I have a studio and I have my students waiting for me. So I have to go. Thank you very much.
Thank you, Labna.
Thank you. Bye-bye.
Okay, bye.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Yes. All right. Now, in this situation, I think since there are no more questions from any of the presenters, let me try and conclude the session. I'm afraid before I came to chair the sessions, two presenters have presented earlier than the scheduled time, it seems, because I was more or less on a little bit earlier than the scheduled time. But it seems the session had started earlier, and I apologize for not being around. But we had very interesting presentations today from Dr. Suryanto, Dr. Mohammed, Ms. Fatma, and Dr. Lobna. And some of them related to post-surgery improvements and breathing. Yes, sorry?
Sorry, Dr. Bahrain. Sorry, Dr. Ranjith. There's one more presenter.
Is there another presenter?
Yeah.
Who is this?
No, Adina.
All right.
Okay, yeah.
Noraslina?
Yes.
Yeah, okay. Okay, let's hear from Noraslina. I didn't see her because I called for her name previously and she wasn't around.
Okay, Assalamualaikum and good afternoon to Prof. Ranjith. My name is Fazina Hajazli and I'm from Center for Nursing Studies, Faculty of Health Sciences, UiTM Kuala. So today, on behalf of my group, I would like to present our paper with the title of Association Between Knowledge, Attitude and Also Practice on Gestational Diabetes Mellitus among Antenatal Women in Community Health Clinics in Selangor. So this is my presentation outline. Okay. So, most of married women wish to conceive soon after marriage, and they are expecting an uneventful process of pregnancy and also the labor. But however, not all pregnant women will have an uneventful pregnancy as they have a high risk to get such a medical conditions, for example, anemia, gestational diabetes mellitus. And gestational diabetes mellitus, or normally called as GDM, is defined as a glucose intolerance with the first recognition during pregnancy according to American Diabetes Association in 2014. And according to Deganathan and Karala Singham in 2012 stated that the incidence of GDM in Malaysia was reported as 8.66% in 2011 and it was increased to 8.83% in 2012, and where the GDM rates were higher from the pre-existing diabetes in both years. And in Selangor, Legapodi et al. Had stated that the prevalence of GDM among new registered antenatal women was 37.9% from the total of 184 in January 2014, and this was slightly higher from the study before. And in Gombak itself, the prevalence of GDM was 1,892 cases in 2017, which represented about 14.64% of total antenatal population, and it was dramatically increased to 16.14% just from January to July 2018. And statistics from the WHO have shown that about 422 million adults in the world were living with diabetes in 2014, if compared to only 108 million in 1980, and these statistically will be assuming to be increased more than 592 million in less than 25 years.
Noraslina, are you changing the slides? We don't see the change of slides.
Yeah, I'm changing the slide.
You are at the content outline still. We don't see the change. I believe you are below.
Slide show dia tak nampak.
Now
So can you see my slide here? Slide number 4?
Now we see the introduction slide, yes.
Okay, statistics from the WHO showed that about 422 million adults in the world were living in diabetes in 2014, and if compared to only 108 million in 1980. And this statistic will be assuming to be increased more than 592 million in less than 25 years. And in 2030, there will be a double projection of deaths from the complication of type 2 diabetes mellitus. And the increasing prevalence of this GDM and also later become a type 2 diabetes mellitus in our community right now was an alarming public health issues, and these need to be identified. What is the exact causes of the increasing in number? And therefore, the aim of this study is to identify the association between the knowledge, attitude, and practice of the antenatal woman towards the GDM. based from the previous study has shown that most of the antenatal women had low level of knowledge as they assumed that the GDM only occurred during pregnancy and it will be resolved just after delivery and no other consequences will be occurred after that. And according to previous study related to the attitude towards GDM, most of the study finding also showed that low level of attitudes on this, especially on the self-management towards the GDM. And meanwhile, for the practice of the GDM, study by Arct et al. In 2017 has showed that their respondent, which is a public healthcare worker, only have a basic practice on the GDM management where they always referred the cases, even though with the simple management to the family medicine specialist. And according to other study by Yizukanzi and Wakana Saleh 2018 had showed that their finding had a fair practice score and only 17.6% of their respondents had physical activity. And this shows that most of the study finding shows that the respondent had low practice towards the GDM. So in this study, we are using a cross-sectional study design which is done in selected public health clinics in Gombak area. For your information, the Gombak district was the second largest district in Selangor out of 9 districts with a cover area of 839.1 kilometers square with a total population of 230,000 people. And in this Gombak district, we have 10 public health clinics with a maternal child health department, which provided services for the antenatal women. And the target population for this study was a pregnant woman who came into the maternal and child health department during the study period. And in this study, we are using the cluster proportionate random sampling method where only 6 clinics were being chosen out of 10 because we have been clustered the Gombak district into 6 zones as to make sure that all the clinic will be covered and the finding from this study can be representative of the whole population for the Gombak. And some of the antenatal women from these 6 clinics will become the total population of our study. And here shown the sample size of the study where about 1,475 antenatal women were the total population of the study. And out of that, after being added with 20% of the attrition rate, so we are recruiting about 366 women with the sample after we have been added with 20% of the attrition rate. And this is the distribution of the sample according to the 6 selected clinics. And the inclusion criteria for this study was an antenatal woman with a GDM, a multi-gravida, and also age more than 18 years old. Why we are choosing age more than 18 years old? Because for the consent purposes. And for the exclusion criteria for this study was a primary gravida, pseudo-primary gravida, because we do not know whether they had been diagnosed with the GDM. Either previously they already have a GDM but undiagnosed with diabetes mellitus. Then antenatal woman with pre-existing type 2 diabetes mellitus and also illiterate in Malay or English. So a self-administered questionnaire was used in this study and it was provided in bilingual, which are English and also Malay. And the questionnaire was distributed into 4 sections, which are Section A for socio-demographic data, Section B for knowledge towards GDM, Section C for attitude towards GDM, and Section D for practice towards GDM. And the questionnaire was derived based from the previous study by Herat et al. 2017 and also Bawat Harani et al. 2017. And the written permission to use this instrument was sought and granted via email from the author. And the detail of the instrument had been modified and adjusted according to the culture and belief of the Malaysian context with a further advice sought from the family medicine specialist, which was reviewed the proposed questionnaire together with the suggestion by the senior doctor of MCH unit, nursing lecturer with midwifery background together with clinical experience of the researcher. And reliability of the instrument was done with a combat alpha test with a value of 0.714, and pilot study was conducted after granted a permission from National Medical Research Registration and Jabatan Kesihatan Negeri Selangor to 10% of the total respondents who met the inclusion criteria at the study setting, which was 40 respondents. This is the result for the combat alpha. And for the data collection process, the researcher did that data collection with the help of a data collector who was the nurse in charge of the respondents. And the researcher was at the study area every day from 2nd to 13th April 2019. And respondents were randomly selected at the study setting area who met the inclusion criteria. And for the data analysis, SPSS version 23 was used to analyze the data. And the statistical test used was descriptive analysis, inferential statistic was which are chi-square, Fisher exact test, and also logistic regressions. For the study finding, the response rates for this study was 98.9%, and for the demographic characteristic, finding shows that age group of the respondent was less than 35 years old, with Malay ethnicity, which represented 84.4%, married women, and tertiary education was most among the respondents, which represented 56.3%. And most of our respondents was employed women and also no history of DVM before. For the level of knowledge, findings from this study showed that a mean score for total knowledge was 8.80 plus minus 1.383, and most of the total respondents had high level of knowledge on DDM, which represented 87.6%. For the level of attitude, the finding shows that the most of our respondents had total score of 40, which represented 15.5%, followed by 38 and 39 score, which represented 11.3% and 10.5% respectively. And result also shows that most of the respondents were moderate level of attitude, which represented 49.5%. The mean score for the total attitude was 23.51 plus minus 2.51, with the highest score was 30 and the lowest score was 14. And only 0.3%, which represented one respondent, had high score, and more than half of the total respondent had good practice towards GTM, which represented 54.1%. For the association between level of knowledge, level of attitude and practice with socio-demographic characteristic, finding shows that only marital status, educational level, and occupation had a statistically significant with socio-demographic characteristic, represented 0.042, 0.007, and 0.040 respectively. Meanwhile, for the level of attitude, for the level of attitude and also the level of practice, only level of education had statistically significant with the p-value of 0.01 here, and also 0.026 respectively. For the association between the level of knowledge, between level of knowledge with level of attitude, level of knowledge with level of practice, and level of attitude with level of practice on GDM. This table summarizes the finding, which shows that only level of knowledge has statistically significant with level of attitude. And finding from this logistic regression had shown that in 1 point increase on knowledge was correspond to increase practice of 0.059, meanwhile in 1 point increase on attitude was correspond to increase on 0.088 on practice. And finding also shows that there is a positive relationship between level of attitude with level of practice and level of knowledge with level of practice, and had strong relationship between level of practice and level of attitude. Even though there is a positive relationship, but p-value for both level of knowledge and level of attitude does not show any statistically significant, as the p-value is more than 0.05. For the discussion, this was the first study done in Malaysia related to KAP of the GM, where most of the previous study was only focused on type 2 diabetes mellitus, but only one study had been done on exploring the knowledge rather than attitude and practice. This study found that only educational level was statistically associated with KAP level of the GDM. And this was similar to a study by Bomi et al. In 2018, stated that the educational level until university was one of the factors to have a good knowledge of GDM. Finding also shows that level of knowledge was high among respondents, and this was inconsistent with studies by Sri Ram et al. And Bawat-Harani et al., where their study findings showed level of knowledge on GDM was low among their respondents. For the level of attitude, this study had found that near half of the respondents had moderate level of attitude on GDM, and this was similar with Islam et al., where most of their total respondents had a positive attitude regarding control of GDM, investigation, and had positive response for GDM education program. And this was in contrast with a study by Hussein et al. 2014 on the study to evaluate knowledge, attitude, and treatment satisfaction on GDM towards their disease, which resulted in more than half of their total respondents having a negative attitude towards GDM. Most of the respondents in this study had good practice on GDM, with the highest score are related to prevent complications such as monitoring baby's movement, planning for contraceptive method, and related to dietary intake of GDM. Because there is limited study found in this area, therefore, researcher couldn't found the article in order to previous article in order to make a comparison. However, a study by Azam, Side, and Kasim in 2018 on related to knowledge, attitude, and practice regarding anemia, because anemia also one of the medical condition that might occur during pregnant. So we have been comparing with this study, shows that pregnant women in Putrajaya had found that the mean score for total practice was 69.9 plus minus 13.1 for practice score, which was low if compared to mean score for knowledge, which was considered as high with mean score of 84.2. In this study, educational level was found statistically significant with level of knowledge, attitude, and level of practice with p-value of less than 0.05. This was similar to a study by Bomi et al. In 2018 found that age below 30 years old, a high income group, level of education until university, health professional, and had a family history of diabetes was found statistically significant with good knowledge score. And in this study, only level of knowledge and level of attitude had a statistically significant, and this finding was similar with study by Yizukanzi and Wanakasali 2018, with their study aims to establish awareness of level of knowledge, attitude, and practice among pregnant women attending antenatal care had found similarities with these study findings. However, even though the knowledge is there, but the attitude and practice was still not so good. Logistic regression analysis found that the level of knowledge and attitude of a respondent could not be the predictor to have a good practice on GDM among respondents. And for the recommendations, findings from this study indicate that knowledge only can be a predictor to increase awareness of the public regarding GDM. Even antenatal women understood the impact of GDM on them and their fetus, they still not practice every knowledge they had in their daily life, especially in preventing complications caused by the GDM. Future research needs to be carried out in order to explore the practice and attitude of antenatal women regarding GDM, as this not only can cause harm to them and fetus, but also increase their chances to get non-communicable disease such as diabetes mellitus in later life. Future research also needs to explore on the health education methods used, whether it is still relevant or need to use new methods for health education programs. With that, thank you.
Thank you very much, Ms. Nora Selina, for that very interesting study about the diabetes mellitus situation of the antenatal women in Malaysia. And I think you constructed a very, very meaningful study that connects the relationships between knowledge, attitude, and practice, all of which I think probably needs to be influenced by medical or any other external agencies to try and arrest the situation. The diabetes seems to be going out of control, not only in Malaysia, but around the world as well. Now, it is not only among antenatal women, but I think among others as well, the situation is an epidemic. I would like to ask you about the attitude particularly, because attitude is something, knowledge, of course, it can be influenced. We can bring knowledge to antenatal women, try and improve their understanding so that they could get involved in the practice. But attitude, what do you think can be done about the attitude? Although there is a very strong relationship between attitude and practice, isn't it? I cannot hear you. I cannot hear you. Did you get my question?
Can you repeat your question? I can't hear your question. What attitude?
I was asking the question that you have established the relationship between knowledge, attitude, and practice. And among the three, knowledge can be influenced by external agencies. We can bring knowledge to antenatal women to try and deal with the situation. But attitude, what can be done about attitude, do you think?
Okay, so in my opinion, I know it is very difficult for us to change the people's attitude, right? Because
yeah, exactly.
Are related to behavior. So as I said earlier, even though they have the knowledge, they have the awareness, but we as a healthcare provider cannot what we call to change their attitude, because the attitude is more related to behavior. So it is more for, on the patient's factor itself. So I think maybe, so in my opinion, sometimes the attitude to something may be influenced by the environment also. So here in my opinion, because that's why I'm focusing on the health education program. So maybe for the future research, maybe can be explored why their attitude towards one of the disease cannot be improved or have a poor attitude for one disease. Maybe because their understanding towards the disease is not so well. Because nowadays a lot of information they can get, but whether the information they get is genuine, is truly, or whether it can be trusted or not. So maybe it can contribute to the attitude, and it can contribute to even after the attitude and also the behavior, and later it will contribute to the practice of an individual. So I strongly believe that because nowadays, especially during pandemic COVID, so right now we have, even though you are not in front of us, but we still can have a conversation, right? So maybe the health education program can be changed in order to what can gain more awareness, can give more knowledge to our public, especially regarding what are the real thing right now. So maybe because as I said before, most of the pregnant women, I also have an interview some of them with my patients before.
Yeah.
So they said that, oh, I just only have a GDM and it will be resolved after pregnant. So I said, yes, it will be resolved. Maybe you will be resolved after you have taken MODTT after postnatal. But bear in mind, study had been shown that in 5 years later, if you are not having a healthy lifestyle, you will have a type 2 diabetes mellitus. And we know, everybody knows that type 2 diabetes mellitus have many comorbidities that can cause so many complications to an individual. It can cause morbidity and also mortality.
Yeah. Okay. Sounds interesting. It's a very difficult and tough task to arrest the epidemic of the diabetes, isn't it? It is not only among, I was saying that it is not only among the antenatal women, but it is in the general population as well. So it's a common problem. And as you were rightly saying, attitude is the most serious obstacle to dealing with it, because attitude cannot be changed. It is inbuilt and it is born with and it is personal. And I don't know how medical services or external agencies can influence attitudes. Perhaps knowledge can. Do you think knowledge, increasing in knowledge, influences attitude changes, attitudinal changes?
So you asked me question whether if increasing the knowledge, the attitude and also practice will increase.
Yeah, can it also change? Is there a strong relationship?
Finding from my study also have shown that all my respondents have a high knowledge. They have a moderate level of attitude, and they also have a high level of practice. But why? But why the statistic is still increasing? So I'm so concerned because based from my observation, about 25%, it is more than less, about 25% of the antenatal women who came to the MCH clinic will have a GDM, and it will be increasing day by day. Even though just a primigravida mother, just for first time pregnant women, will have this. They are also in the statistic. So it is very difficult for us as a healthcare worker, especially I've been working in a public health setting. So I have an experience working in a public health setting and also working in a hospital. When you work in a hospital setting, because the people there is already sick. So when you told them anything, they will follow what your orders, you know. But when the people in the public health, they don't have a disease, but they have they will have later. They might have the complication. So that's why we in a public health community setting, we need to emphasize on the primary prevention method. So because the primary prevention method is one of the approach that we can prevent, we can protect that individual to get a disease later. So that is why we have to do in a public health setting. So we need to emphasize on the health education. We need to empower our healthcare workers, educate people in order to increase their awareness. But we need to parallel with the environment, with the system, because I think maybe because of the health education method used right now is still a conventional method. You know, we still are using flip charts. So because most of individuals, we have a smartphone, right? So why we always look at our smartphone? Because we think, oh, we have a visual, we have an audio visual that will make people interest. So maybe in the future, we will explore on the new health education method, which maybe can give an impact, can give more awareness, we need to have a more statistic. We put a statistic for what are the consequences that they might get when they have a GDM and later a type 2 diabetes mellitus. So that is my
Thank you. Thank you. Yeah, thank you very much, Noraslina. I would like to open the discussion if there is anyone who wants to make any observation or make a comment. We have a couple of minutes before we can finish the session. there any question from anybody in the audience or from the business? Anyone has question or observation? No, it doesn't look like anyone has any questions to raise. In this case, I think I will close the session. I'm very thankful to all the presenters. I'm sorry I was not there for the first two presentations, but we had Dr. Suryanto, Dr. Lobna, Dr. Mohammed, and Ms. Fatma and Ms. Noraslina talking about a variety of issues, but most of which were related to medical issues of breathing, improving breathing exercises after surgery, and impact of dietary COVID-19 on dietary habits. And we had discussions on the quality of life in Saudi Arabia, and now finally about the improvement of diabetes status through knowledge and attitudes and practices and so on. And it's a very interesting session, which shows that the quality of life is not an easy task to deal with, and we need to approach the issue with all sorts of different disciplinary approaches, as well as practices that the academics will need to try and improve on a daily basis. I am very thankful to all the presenters who had organized the presentations very systematically and talk eloquently at this international conference. And we look forward to see you next time at the next conference in the Quality of Life Conference. Thank you very much indeed. Over to you.
Thank you, Prof. Ranjith. Thank you very much.
All right. Okay. Assalamualaikum and a very good morning. I think still morning. I hope everyone can hear me clearly. So the study that I'm sharing is perception of soft contact lens usage among health sciences and business management students. Okay, we know that contact lens has been used for the therapeutic reason, for correcting refractive error, and also for cosmetic. And most of the prevalent wearers are the students and also the young workers. So, and most of the prevalent wearers are mostly soft contact lens wearers. The reason why soft contact lens wearers is preferable, one of the reason is because of it's made up of water, is easy to wear, is easy to be adapted, and it does not deform any complication towards a cornea. And however, even though the contact lens wearer is higher, but the awareness of soft contact lens wearer in terms of perception, in terms of their knowledge on taking care of contact lens is still critically worrying, and it includes the knowledge regarding the benefit to the wearers and also the complication related to the contact lens. And knowledge of contact lens is fundamental in terms of different type of contact lens and the use of contact lens in the market. Okay. According to a study done in 2017, the 95.8% of the student has some knowledge on the contact lens, while the rest is ignorance of this contact lens knowledge. But there's also a study by NIH at the same year saying that most of the students that wear contact lens is still lacking on the proper knowledge of the contact lens. So this issue is still inconclusive. We can say that there's no concrete answer for this issue, and it is still need to be discussed. So the ocular health education, including the proper contact lens wear practice, is crucial in preventing especially the contact lens complication, because most of the complication is due to the infections, microbial infection, and 84% of the participant, according to Kumar 2030, is still had no knowledge on contact lens complication, even though they has higher education level. And the personal experience and education institution is a very significant factor that can influence on the contact lens knowledge, because the reason or one of the criteria to wear contact lens is good hygiene and proper knowledge on the maintenance and care of the contact lens. And poor hygiene, as I said before, can cause severe microbial infection towards the eye. All right. And education on various alternatives need to be done to educate people, enhance awareness, and create new positive attitude toward that. So this study is done because we want to see, even though we want to see among health sciences that has basic of contact lens usage probably compared to the business management students, how their level of perception and knowledge towards contact lens wear. So we gathered the data from a patient that have enter or that have undergone eye checkup in UiTM Vision Care Clinic. So we gather all the information, all the data from Health Sciences and Faculty of Business, and we give the questionnaire for them, the Perception and Practice of Contact Lens Use Questionnaire, PPCLUQ, to those students. And the questionnaire comprised of 27 contact lens related questionnaire regarding the perception and also the awareness of the contact lens. And all of the answered questionnaire has been analyzed with independent t-tests. Okay, so demographically, there are 52 of them from health sciences and 48 of them from the business, and most of them are 20 to 25 years old, young adult. And for the perception of contact lens use in general, we ask both group, health sciences and business management, because in that two groups, they have spectacle and contact lens wearer. And in general, the spectacle wearers, they think that, in both groups, they think that contact lens is difficult to be wear. And they think that spectacle is more comfortable. They also think that contact lens might be harmful to the eye. And in terms of cost, most of the spectacle wearer agreed that the contact lens are more expensive than spectacle. And in terms of complication, the spectacle wearers think that they do not wear contact lens because of contact lens can lead to infection. But for the opinion based on the contact lens wearer, they think one of the complications that they had when wearing contact lens is discomfort and dryness at the end of the day or in the evening. So, but all of the comparison perception between spectacle and contact lens wearer in terms of general cost and complication, the p-value are significant, less than 0.05. And we did comparison between health sciences and business management students, and in terms of reason why they wear contact lens, and in terms of concern of wearing contact lens, and also the knowledge of contact lens use. And the mean value, the highest mean value is for the reason they started to wear contact lens is due to the restriction or limitation movement of spectacle. Okay, both group agreed and mostly agreed that the contact lens use, the reason is because of limitation of movement. Okay, the concern, the highest concern is the comfortness in the aspect of choosing the type of contact lens, and the knowledge, for the knowledge of contact lens, both groups know that know or aware of their lifespan of contact lens at the time of prescription, meaning to say when they're buying the contact lens, they know how long is the contact lens, how the type of the contact lens. All right, but for all of the reason, or for all of the aspect that we asking them in terms of perception, all of the variables show that they have the same, or there's no significant difference between two groups in terms of reason, concern, or knowledge to answer the perception of contact lens between two groups. Okay, for the discussion, in general, both groups, spectacle and contact lens wearer, why they think that spectacle, why the spectacle wearers think that contact lens is difficult to wear, because most of them never wear contact lens before. And then according to Among, it corroborate with the finding by Among that 54% respondent reported that spectacle are superior to contact lens. So most of us think that spectacle is easier than contact lens. And then spectacle wearer agreed that contact lens are more expensive. Yes, it indeed responds to all of the findings by Kumar and a few studies showing that yes, contact lens is more expensive than spectacle, and this is one of the reason is lack of experience. Lack of experience with the contact lens and not knowing the exact cost of contact lens. This is the reason why they think that contact lens is more expensive than spectacle. In terms of complication, both groups agreed that concern regarding infection, related contact lens, and itchiness was the main issue. Yes, it's reported that itchy was the top concern among non-contact lens. They don't want to wear contact lens because they think contact lens can cause itchiness. In comparison of business management and health sciences, we want to see either the different background can cause different perception. But for the use or concern, for the contact lens use, concern, and also the knowledge, there was no significant, meaning to say both group has almost equal or the same perception toward contact lens. They think that reason why they wear contact lens because they think they are restricted with the spectacle. But it is contradict with the current studies and a few studies that showing that the limitation of movement is the least preferred reason for starting to wear contact lens. So we can say that the discrepancy may be due to the difference of the purpose of wearing contact lens. So different people, different purpose, and different reason why they wearing contact lens, why they started wearing contact lens. But in terms of perception, control progression of refractive error was the least preferred reason, maybe because they think that the progression of refractive error can be corrected by the spectacle as well. And for the comfortness, 75.8% reported by Zoo that comfort while wearing contact lens was important consideration, and it followed by the price, cosmetic, and also selecting type of the contact lens itself. Okay, but in terms of knowledge, both groups showing that they are aware of lens care and handling and also purchasing the contact lens, and they agreed that they were informed about the potential complication of the contact lens use and aware of the contact lens lifespan, 1 month, 3 months, and also 1 day. The current finding corroborate with this study, with this study that we have done, that showing that 71.7% had shown sufficient knowledge about the contact lens use, and but this is maybe due to the abundance of information at the internet, on the internet, and also on the social media and other awareness programs. And we can say that both group, business and also the health sciences, they have a similar perspective toward the contact lens awareness. So as a conclusion, the perception of contact lens among spectacle and non-spectacle wearers were different in terms of contact lens in general, costs and also difficulties. However, the contact lens wearer have the same behavior assessment of awareness regardless of their education background. Either they are health sciences students or either they are business management student. The awareness are almost the same, and proper contact lens with the proper contact lens guidelines and knowledge supplied by the clinician or supplied by the optometrist especially will help to protect public health and improve the quality of life. This is the main point that we want to do, is to improve the quality of life, not only just for the spectacle wearers but also for all wearers that want to correct their refractive error. So future research that will be interesting to do on the perception of contact lens use in multiracial setting. We want to see is either Indian, Malay or Chinese has a different perception on the soft contact lens because they have different size of iris and different size of pupil, different color of iris, and it will be a good setting for a comprehensive approach. Thank you very much.
Assalamualaikum and very good morning to all of you. Today, I will present the finding of our research here with the topic physiological impact and social supports received during COVID-19 among nursing students. So as the background of the study, as we know, the WHO has issued a warning about the COVID-19 crisis, give a potential effect on the health and social care worker mental health. The previous pandemics involving SARS and MERS raised worries due to impact of the several mental comorbidities, including depression, anxiety, stress, and other symptoms. In Malaysia, the first case of the COVID-19 was detected on 25th January 2020. The upbeat cases beyond 53 cases instance urged the PMs announced movement control order to reduce the rapid spread of the COVID-19. All the institution was closed due to this decree. The closure of the school, business, and the imposition of the travel restrictions leads to long-term physiological problems among communities. Okay, therefore, the objective of the study is to identify the physiological impact and social supports received among nursing students in UiTM Puncak Alam during COVID-19. And the second objective is to identify the relationship between demographic factors such as year of study with the physiological impacts among nursing students in UiTM Puncak Alam during COVID-19. So in the literature, it says here, depression 2020 depression statistic globally increased more than 2,064 million people affected. According to Browning's 2021, a woman or those aged 18 to 24 indicate substantial level of the physiological damage. And Orizola found undergraduate student has substantial depression, anxiety, and stress level than a master students during the COVID-19. In terms of the social support is psychological resources available through interpersonal connection and one social network, and a lack of the social support is well known a predictor of the mental health issue. So, the methodology of the study is using a cross-sectional study among full-time nursing students, year 2 until year 4 that are registered during March and July 2020 per semester. We use a simple random sampling, and using a online random generator and distributes the online questionnaire for them. There's a 2 set of the questionnaire, including the demographic data and the DAS for the psychological impact, and the social support we use a questionnaire from the LAO. And all the data analysis using SPSS. And for the result, we found here, because this is a nursing student, majority of the student is a female, 88.8%. And they are, during the MCO, they are staying with 83.3% staying with the family member. But there is a 90 student that are stranded in the university during the MCO. For the psychological impact of the nursing student during the COVID-19, we can see here, there is a normal depression reported. However, in terms of anxiety, even though 3 students reported they have extremely severe anxiety during the COVID-19. In terms of stress, majority they feel they are in the normal. Look at the mean also, they are in the category normal and mild stress. Okay. So, in terms of the social support received by students during COVID-19, we can see here, majority of the support will increase during the COVID-19, support from the friend and also support from the family member. And also, they also becoming more caring to the family member during the COVID-19. Okay, when we break down to answer the objective number 1, we look at the association between the psychological impact and the social support received during COVID-19. we break out into a subscale, subcategory. So when we look at the relationship between depression and social support, we can see here there is a association here, because with support with the family member and the sharing feeling with the other family member. There is a correlation. There is an association. That means if they are receive a higher support, they become less depressed. For the anxiety, there is no significant. There is only one significant result. If they are receive a support from the friends increase, their anxiety level will be decreased. And we look at the relationship between stress and the social support received during the COVID-19. There is no significant result. Okay, to answer the objective number 2, to look at the relationship between the year of study and depressions during COVID-19, there is a association with the year of study. We look at this, the year 2 student become more depressed compared to year 4 students during the COVID-19. As for the discussions, the level of the psychological impacts among nursing students show between mild to severe depressions and mild to severe anxiety, and 60% is like to severe stress. The result when compared with the others is found quite similar. That show that majority of the student will have anxiety and depressions during the COVID-19. This show that the longer duration of the COVID-19 outbreaks, people anxiety increases. In terms of the social support received among nursing students during the COVID-19 outbreaks, the social support received by them increased among friends and family. It also supported by Liu and Lourdes. Therefore, the effect of the COVID-19 strengthens most of the nursing students' social support system needed during the outbreaks. For the relationship of the physiological impacts among nursing students and the social supports during COVID-19 outbreaks, there was a significant relationship between depression with social support. It showed that increased support from a family member and other will suppress their depression level. Communication will make some feel at ease. As effective communication build trust, prevent and resolve someone's problem, and provide them direction and clarifications. For the relationship of the year of the study and depressions among nursing students during COVID-19 outbreaks, there is a significant association relationship between depression and the year of study. Similarly, depression among students were linked to uncertainty about the grades and suddenly overwhelming academic online tasks and sessions, which contributes to the onset of the COVID-19. As a further step, must be taken to create awareness among academicians that academic workloads and separation from the university during COVID-19 negatively affected the student depression. And for conclusions and recommendations, more than half of the participants in the study show they have a psychological impact during COVID-19. Although there is a psychological impact, especially the anxiety, there was increase in social support received during the outbreak. And there was also relationship between depression and the year of study. And for the recommendations, the best approach to deal with the psychological effect of the COVID-19 is to get advice from professionals. The universities need to pay special attention to those students battling psychological impact, because this question might worsen if left untreated. An online counseling strategy could be beneficial to lessen students' psychological